A special session for Squint, and this is a national symposium on Strabismus. But unfortunately, the target audience, I don't know how much. Anyway, so we start without wasting any time. We are exactly in time. We're starting this symposium. The chairs is myself, Dr. Pradeep Sharma, Dr. Pandey, Subha Dadia, Amita Vain, Shreya. Shreya, you can join there. So with this, we start the first topic, and that is current status of neurovision therapy in amblyopia. She is not here. I'm sorry. So then, Suchita, please.
लेफ्ट की शुरू कहाँ से कर रहे हो?
इधर से
सुचेता
लेफ्ट नहीं वो बता देंगे ना इनका लोड हाँ ठीक she'll be speaking on current concepts in management of esotropia. You have 8 minutes.
Very good morning to all of you, and I should thank the AIOS and Dr. Dadia for giving me this opportunity. Basically, I'll be talking on the current concepts in diagnosis and management of acute acquired esotropia. I have no financial interest in this presentation. What is acute acquired concomitant esotropia? It is characterized by sudden onset of strabismus accompanied by diplopia with no significant changes in the deviation of angle in different gaze positions. So it is basically classified as acquired committant and incompetent esotropia. And the classical teaching, which was that the acute acquired committant esotropia was 3 types. Type 1 was the Swan type, type 2 was the Buren-Franceschi type, and type 3 was the Belchowski type. But slowly what was added into it was the acute accommodative, decompensated phoria, neurological type, cyclical, and what we are more concerned and which we have seen more in the after COVID period was this excessive near work esotropia. This was another classification which was underdone by Go et al., which showed that excessive near work activities as well as the neurological diseases and extraocular muscle tone was also giving rise to this acute esotropias, and there was other classification also which was made depending on the amount of deviation, whether large angle or small angle deviation. So what exactly is this acute acquired concomitant esotropia? The onset is more than 6 months of age, because we know which is less than 6 months is more like an infantile esotropia. There is no lateral incompetence and it has an acute presentation. What it does not include, which is very important also to rule out, is, or which will be stimulating it, are the acquired 6-nerve palsy, idiopathic intracranial hypertension, and ocular myasthenia gravis. Looking at the incident, this is around 4.9% of all childhood esotropia in a hospital-based setting, and it varies from 14 to 16. So it's actually a rare disease. So we'll come to different cases. This was a 2-year-old child who had been advised somewhere else for a prolonged patching. And we saw that the parents were patching full-time. They had kept the child with the patching for 2 days. So the child was presenting to us 3 weeks after, and this is what is the inward deviation we could see, and this is typically the type 1 or the Swan type. So what exactly occurs over here? There is a monocular occlusion, so there is an artificial disruption of fusion. So when we ask the question, are all children who are patched will be having this type of esotropia? Not all, but all cases, those who have a latent convergent tendency and they have a slim fusional reserve with a loss of this simultaneous binocular perception are likely to undergo this type of acute esotropia. Coming to the second case, this is a 6-year-old female who presents with sudden onset inward deviation of the right eye, and there was a history of a viral infection 1 week back, and you can see the right ET with a 35 prism diopter, and ocular motility was full and free. So this is the typical idiopathic or the Franceschi type, which has a minimal refractive error, no accommodative component, and is usually precipitated by viral infection or a minor head trauma or psychological stress. It's because of this poor fusional divergence, but binocularity is maintained in these cases. Coming to the third type, this was the 7-year-old female. giving a history of voracious reader. She was not using any spectacles, and she had a low vision in both of her eye. Refraction, cycloplegic refraction showed -5 diopter and -6 diopter in both the eye, and PBCT around 45 prisms ET. And this is the typical Belchowski type, which is because of the uncorrected myopia, and it is because of prolonged near work. There will be a small ESO for distance, but they are ortho for near. But slowly as they go on reading more, there is a persistent convergence, increased tone of the medial rectus, and decreased fusional divergence, leading to a constant esotropia. So coming to another case, this is a 8-year-old male who come towards with sudden onset of deviation. Cycloplegic refraction is +6 and +8. The PBCT was 35 prisms ET, prescribed glasses, and then also after 3 months when we saw it is same 30 prisms ET. So the question comes, are we dealing with an acute accommodative type or a refractive accommodative type? Then how do we differentiate? Well, there will be a onset which is a sudden, and in accommodative there will be a large angle deviation, constant deviation, diplopia will be there, and binocularity is usually preserved. And in refractive type, more often it's asthenopic symptoms, and amblyopia and poor binocularity will be there. Coming to this case, this is a 12-year-old female with an inward deviation of the eye, history of using mobile phones and iPads. Visual acuity is almost 6/6. Cycloplegic refraction is not much. And this is what we are dealing with, this new generation's smartphone type of esotropia. So short working distance, they have a postural thing. They go nearer and nearer. They go on seeing, and there is a intense activity and addiction to this mobiles, and they have this type of a esotropia. What we should not forget after doing a cycloplegic refraction and history taking is the fundus examination, because some of these cases can have a papilledema. So acute sudden onset with a nystagmus, if you find, and if you have a papilledema, you are dealing with a case which is more of a neurological type. So the question comes, should all of these cases should have a neuroimaging? Well, we know tumors of cerebellum and Arnold-Chiari malformation is more common in some of these children. Literature says it is around 6 to 30% significant finding on MRI, and Sether all had done the maximum, have the highest study which they are showing that 16% positive findings on MRI and 13% required a further evaluation along with even though the neurological examination was normal. So since there is a lack of consistent predictive factors, it is better to neuroimage. What are the red flag signs of neurological etiology? Older age group, neurological symptoms and signs if they are present. If they have a poor fusion, there are associated nystagmus, and there is a recurrence of esotropia. Well, these are the cases which should have a neuroimaging. What is the management protocol? You give the glass prescription, do a amblyopia therapy, but more of a orthoptic exercises. You can go off about giving them the prism glasses. Fusional divergence exercises may not help much, but it can be done in the form of vision therapy or Broke string. Botox in the initial stages you can give. First injection 50% resolution, but you may require 2 to 3 injections. And then we go about for muscle surgeries, but that only after 8 months, or you have fully seen the patients after doing a prism adaptation test, and you only operate for the largest angle. Well, the surgery is either you opt for a bimedial recession, you do a unilateral MR recession, LR recession, or 3 muscles with adjustable. The important thing which comes is whether we'll do a standard dose or a augmented surgical dose in these cases. And the better prognosis is if you have a good fusion or there is a hypermetropic type. So my take-home message is acute onset concomitant esotropia is an unconfirmed form, and SPART form uses should not be neglected, and abducting nystagmus and lack of binocularity may be sign of an underlying neurological disease. So neuroimaging has to be advised as per the need, and if the esotropia is not resolving. Thank you.
Thank you, Dr. Suchita, for raising a very important thing which is happening more and more, especially the children and are doing indoors and lot of reading work. So we will have all the questions and comments at the end as per the time permits. So we'll move on to the next speaker, and we have none other than a very dedicated strabismus and pediatric ophthalmologist, the president of Symposium, and that is none other than Yogesh Shuklaji, to tell us about current concepts in the management of intermittent exotropia.
On to karo.
No, it's on.
So, well, good afternoon, everybody. This is basically a very controversial topic also, and we have a lot of problems. It's really puzzling, and the enigma of intermittent divergent strabismus. See, intermittent exotropia is common, though enigmatic means it is puzzling. Form of strabismus that presents a modest diagnostic challenge but requires considerable therapeutic challenge intensity. That was what the Eugene Helveston has written. Now, in most patients, vision is usually normal and equal. Sensory fusion is good, stereopsis is good, motor fusion is present, and versions and ductions are intact. In other words, good intermittent strabismus is very good. But when the eye deviates, central binocular cooperation is totally turned off. There is a manifest large exodeviation, large central suppression with monocular vision. The periods of this exodeviation are variable, and so are the complaints of the patient. Now, what are the really puzzling points of ITS? I'm coming directly to those points where I want to stress, The accurate assessment of deviation is a really requires a lot of effort to do. Correct knowledge of the type of IDS. We know that there are so many types of IDS. Listen to the patient, the complaints of the patient, because many a times you will have to operate only on the complaints of the patient because of the cosmetic reasons. Surgical procedures, what are your choice of surgical procedures is again a problem in region. Now I'm going to show you some videos, which has been really counted the real patients. I'm just giving you one example. Now this is a young girl for about 17 or 18. Now when the patient came to me, I'll tell you the complaints which she came to me. Now there's a small deviation, it's basically a phoria. Now see the eye moves in. The eye moves in. Now I gave her spectacles because she had some refractive error also. And even after giving the spectacles correction, she had a small amount of myopia. The exophoria persisted. It was more for the distance actually and less for the near. Now, this patient came to me complaints of headaches. Now the problem is that it's a small deviation, only exophoria, not tropia. Should we operate or not? Number one. Let's go to another patient. A small girl, it's about 6 or 7 years. She was seeing a lot of, mobile. And now see, when I told her to look, the left eye deviated outside. The right eye deviated. See, intermittent divergent strabismus. Very simple. But it's a small angle. It's not a large angle. It's about 25 ppd. Now, the patient came with the complaints that the small girl, because when she used to look outside in the classroom, the eye used to deviate, because now it's deviating as you saw. When I tell the little girl to see for the distance, the eye deviated. The parents were very concerned. The parents were very concerned because the children started teasing her in the school. So, what should be done? Should we operate? We'll talk of that later on. Now, see another boy. Another boy. He had spectacles. Already myopic, I think 3 or 4, I don't know, because a lot of, I'm just giving you one example of each. There is no tropia. There is no tropia, but when you do an alternating closure of the eyes, then the eye deviates. Still the eye deviates. Now, this was near here than exophoria, but when I told the patient to look far, there was a large exodeviation. Again, the same problem. The children in the school were teasing the boy. The parents are worried. And then it's the psychological process starts for the children. Next, another girl. I'm not giving you the videos, but this girl about 10 or 12 years old, and she had a large deviation, also alternate intermittent deviation, and only when when the girl used to look at distance, then only used to ID. This is a standard, and a very common way of presentation that the eye only deviates when you look at distance. So she's a girl, about 12 or 13 years old, and the parents were very worried. Again, same problem, the psychological problems, you going to school, the problems, and, the relatives start saying that, so I had to operate. The simple, as a rule, I always do intermittent divergent squint on adjustable sutures because I don't know. Because I don't know how the patient would fare these. So always next day when I do the adjustments, at least I am little closer to the best of the correction as possible. This I will just leave. This is a congenital esotropia. There's a different topic. I will not go into that. Now, so the take-home message is, I'm very concising it, okay? मैंने आपको जो ज़रूरी चीज़ें थी वो बता दी, because which is the main puzzling factors of this. The age of onset of exotropia should be specifically asked. 4 years with complaint should be judicially treated. Orthoptics, especially converging exercises, should be seriously employed. Intermittent exotropia should be closely watched. Vision and stereovision should be monitored. Fusion breakage with constant exotropia should be surgically. Once the fusion breaks, so we have a lot of criteria that when you should operate, when should you intervene, and when you should employ the surgical procedure. We have a lot of criteria for that, That I think you all know, so I'm not going to that. Fusion, if patient is too young, patching as per regime should be done to maintain the vision. Surgery is also indicated early if complications like DVD, HDH and other things appear. Parents' acceptance for surgery is important. You must take the consent. Of course, if the child, the parents have to be, taken into confidence and consideration. Repeat or second surgery possibility should be explained. Choice of surgical procedures should be sensibly used. Now, I still have half a minute more. Now, the problem is, what do you do in these patients? Young child, exophoria, goes into exotropia when the child looks far, because when in the school, the patient, when the child looks at the board, the eye deviates out. The other thing which is important is that why there is a problem in our establishment of evaluation. There has been a lot of work on this from Johns Hopkins also, and Dr. I forgot his name. I saw his Hunter, Dr. Hunter, David Hunter. See, he had an article I read about last year. He said that we only examine either at 3 meters or 6 meters. When they examined the exotropia for distance even further than 6 meters, there was a lot of difference. And similarly, surgical procedures, when you operate on a patient, which you have evaluated at 3 meters only, you see, the results are only 60%. And if you did your surgery after evaluation at far more distance, even further than 6 meters, they say you tell the patient to look outside into the garden or something, the results were 80%. That was what the David Hunter said. So the problem is that what we are examining, or the alternative is you at least call the patient 3 times every 2 weeks. And again examine. Every time you'll find a difference. The third alternative is you have the prism adaptation test, what we have, but it's a little costly. Fresnel prism lagana is a little costly. Har bar 15 din mein isko change karna is again a costly. But if you can put a prism and again call the patient after 2 weeks, you will find a difference of deviation. Again call the third time, again you will find a difference. And when the last, after a month, when it has stabilized, that is your exact estimation of the deviation. Thank you very much.
Thank you, Professor Shukla, for a very interesting talk. In fact, intermittent exotropias are one of the most difficult clinical situations, and so there's a lot of controversies, a lot of issues. So I think we'll have some discussion at the end of the session. And now next talk will be given by Dr. Leela Mohan. She'll be talking on clinical and surgical implications of rectus muscle pulley, current concepts. Rectus muscle pulleys are another very interesting and challenging area, and she has a lot of extensive experience in motility disorders. Dr. Leela, please.
Thank you, sir. I'm sorry for my sound.
Yeah, you're having bad throat, yeah.
So, clinical and surgical implications of rectus muscle pulley, current concepts. So, the extraocular muscle and the connective tissue around it is much more complex than we traditionally accepted classic concepts. We know that even the extraocular muscle recti have compartmentalization into superior and inferior, the horizontal recti and medial and lateral, and they have their specific functions also. And DEMA has shown almost 3 decades ago by high resolution MRI, when the MRI came in, the dual insertion of extraocular muscle and pulleys, which are actively shifted by extraocular muscle orbital layers. This pulley hypothesis put forth by DEMA has been anatomically proven in cadaver studies later. Recognizing the role of muscle pulleys allows more precise surgical interventions and ensures better postoperative outcomes, minimizing the risk of complications. So, the pulley concept, which is a revolution in the concept of orbital anatomy, ever after the demonstration of pulleys in the beginning of 21st century, there is a lot of controversy regarding its existence. And in 2002, DEMA has shown the constituents of the pulley consisting of collagen, elastin and smooth muscle fibers, and this has a dense musculofibroelastic constitution, 2 millimeter in length, histopathologically and immunohistochemistry proved, surrounding the extraocular muscles in a sleeve-like manner just posterior to the T-nuts, and the surgical utilization of this pulley can be useful in incontinent strabismus. By Mason's trichrome staining, global and orbital layers have been demonstrated in, and there's an anatomy journal which has shown in 2024 the presence of these pulleys. Passive pulleys theorizes that extraocular muscle slides freely through the pulley sleeves, and active pulley hypothesizes that the orbital layer inserts in the pulley and moves them horizontally. This is by high resolution MRI, it has been shown the global layer attaching to the sclera on the eyeball and a small orbital layer which goes and gets attached to the connective tissue around it. And the pulley controls the extraocular muscle path and serves as the functional origin. And the orbital fibers actively help in the rotation of the eye. There are some calculations for the rotation, how much it happens. And MRI taken in the coronal plane just posterior to the equator has shown the clockwise and anti-clockwise. Clockwise rotation in the right and anti-clockwise in the left produces an A pattern, and vice versa, producing a V pattern. And these are mostly congenital or which is seen in long-standing strabismus. And Burt and Kushner has shown that V pattern always, with inferior oblique overaction also, doesn't always collapse after inferior oblique recession. It may be due to the heterotopy of pulleys. And childhood onset pulley anomalies are sometimes seen by the orbital anomalies as in Crusen's. And acquired pulley defects has shown the sagging of the lateral, sagging of the eye because of the regeneration of the bands between lateral rectus and superior rectus. This is a V pattern exotropia, where there is pulley heterotopy seen in the MRI, and also on table we can see that the muscle is, the anterior part insertion is normal, but the posterior belly comes from below, and then in which case you may have to displace the muscle instead of doing the inferior oblique recession. So there is still not a very clear-cut clinical examination that it is an infero-oblique overaction or pulley heterotopy. It can occur even in heterotopy, it can show an over-elevation in adduction. So acquired pulley dysfunction, as we see in sagging eye syndrome here, there is a ruptured and absent band between the superior rectus and lateral rectus. And in these cases, some clues are the deep superior sulci, ptosis and orbital fat loss in old people where there is a esophoria, esotropia for distance. So clinical assessment, facial inspection for any presence of orbital anomaly, compare the lateral and medial canthal positions. The palpebral fissure slant may give a clue as to the heterotopy and rotation of the eyeball, and look for orbital asymmetry. Look for versions and also 9-gaze PBCT in elevation and depression, which gives the pattern. And when to do an MRI in esotropia for distance only with suspected abduction limitation, MRI can confirm the presence of extortion. Large axial length also above normal may point to heterotopy. And often these displacements are seen on the table during intraoperatively. So surgical implications to restore normal pulley location and function in heterotopy, minimize pulley utilization can minimize trauma to muscle and sclera, and they are potentially reversible also. This is an upward displacement of lateral rectus in heterotopy where there is a pulley extortion. When on the table you can see as and when you hook, the muscle is coming from below upward, and you can do a displacement of the muscle upward to produce one muscle width or half muscle width according to how much is the V, and collapse this V pattern. So for want of time, I will go ahead. This is one place where pulley can be, the muscle displacement can be done in a pulley heterotopy. So medial rectus scleral fixation, that is Fadden versus pulley fixation. Pulley fixation versus retroequatorial myopic sclera. So this is a comparison of the Fadden and the pulley fixation, where the extensive dissection is not needed for pulley fixation. It can be done either after recession or before recession. We can take the and that what you are seeing is the pulley. You need a good assistant to pull the eye well away from the muscle, so that you get a good bite from the sclera, from the pulley. So this 5-year-old child presented with acquired esotropia, accommodative esotropia, repeated atrorefraction showed there is a near-distant disparity. Pulley posterior fixation requires a long, strong adjacent pulley. So medial rectus is the best in giving good outcome. And inferior rectus and superior rectus not so much. And lateral rectus, of course, even Fadden is not it doesn't give good results in faddening lateral recti. So this is after pulley fixation. This child had no esotropia for near as well, and it maintained. He comes even now, and I have started reducing his accommodative hypermetropic correction. So he is fully corrected for distance also, no distance and near with glass. So pulleys are fundamental to ocular motility. Pulley fixation is effective in convergence excess type and small partially accommodative esotropia as well. And utilizing pulley reduces the risk of scleral perforation and saves time as well. Thank you.
Thank you, Dr. Leela, for very interesting talk. Pulley problems are anyway very diverse and very challenging and interesting. I think we should keep in mind craniofacial disorders, trauma, and things like Marfan's. And the next talk is by Dr. Professor Subhash Dadia. He doesn't need any introduction. and he'll be talking on monocular elevation deficiency, modified Nishidas procedure, current status. Professor Subhash, please.
Very good morning to one and all. Thank you, respected chairman, sirs, and dear friends. Basically, monocular elevation deficiency is characterized by limited ability to elevate the affected eye in any gaze position while maintaining normal reductions in all other gaze. And this MBD is classified into 3 types. Initial term was double elevator palsy, which was coined by Dunlop. It may be congenital or acquired, paretic or restrictive, supranuclear. However, MED is more accurate term as there can be paralysis of both muscles independently and supranuclear lesions can lead to impaired unilateral upgaze palsy. It is classified into type 1, type 2 and type 3. In type 1, there is tight inferior rectus with positive FTT for inferior rectus, poor bells. In type 2, there is primary superior rectus palsy and ability is free for inferior rectus, and type 3 is supranuclear with good bells, negative FDT and intact scatic velocities below midline and normal above midline. Patient can present with vertical misalignment of eyes, drooping of upper lid, diplopia, abnormal head posture, inability to elevate the affected eye and decrease in vision. There is presence of hypotropia, presence of ptosis and pseudotosis. There is limitation of elevation above midline, which is equal in all 3 horizontal gaze. This is adduction, primary position and abduction. Bell's phenomena is absent in IR restriction and SR palsy. Amblyopia is seen in congenital cases. Abnormal head posture, typically chin elevation is there. So this is clinical photograph of patient of left MED showing all features. Another case of MED. Another case of MED. Then we have to differentiate between congenital and acquired MED. This is a 20-year-old female with post-traumatic MED, and FTT was suggestive of tight IR. It may be congenital or acquired. In congenital, it is primary inferior rectus restriction, superior rectus paresis, and supranuclear palsies. In acquired, it may be due to trauma, tumors, cerebral vascular diseases, metastatic tumors, sarcoidosis, cysticercosis of muscle, and thyroid eye disease. So it is very important to differentiate congenital MED from acquired MED, and most important feature is presence onset since birth, and secondly presence of strabismus and ptosis are the features of congenital MED, while acute onset diplopia in primary gaze and upgaze is seen in acquired MED, and ptosis is usually not a classical feature of acquired MED. Investigations are systemic workup, thyroid profile, X-ray, CT, MRI, USG. These are the various differential diagnoses for congenital and acquired MED. This is case of acquired MED due to cysticercosis and was treated. And these are the photograph after oral albendazole and steroids. Indications for surgery are abnormal head posture, significant vertical deviation in primary position, contracted binocular fields, and diplopia in primary position. And in some cases, only observation is required. With limited head changes, patient can maintain orthophoria. Goals of surgery are to achieve cosmetically acceptable deviation in primary position, to increase the field of binocular vision, to counsel the patient that more than one surgery is required. Ptosis surgery should be done after strabismus surgery, and it cannot cure MED completely. Various treatment options are NEPS procedure, modified NEPS procedure, augmented NEPS procedure, vertical muscle resection, contralateral superior rectus resection, contralateral superior rectus resection with Fardens, resection of inferior oblique, resection of contralateral inferior rectus, and recently this modified Nishidas procedure has been tried in MED. So what are the drawbacks of NEPS procedure? It is not a graded procedure. Residual hypotropia is there, horizontal deviation is there, then difficult to treat, horizontal motility restrictions, hypertropia which worsens with time, diplopia and lower lid retractions, and anterior segment ischemia, there is risk of anterior segment ischemia. So this Nishida's procedure, due to its success and versatility, this procedure has been applied to range of other clinical situations, including Duane's retraction syndrome, third nerve palsy, transected medial rectus, MR hypoplasia, and sixth nerve palsy. And recently, there were case reports of Nishida's procedure being tried in isolated cases of MAD. So, in a study by Murthy et al., this Nishida procedure was performed in addition to IR recession in 2 patients of MAD, and only in 1 patient this Nishida procedure was done, and correction attained was that they were able to correct approximately 30 prism diopter of hypertrophy in conjunction with inferior rectus recession. It was 40 prism diopters of the correction. Then another study was done by Sweta et al., and in that study they have treated 7 patients in which they have done full tendon modified Nishida's surgery, and the average correction was around 52 prism diopters. So based on these reports, we have given a thesis at our center, and one study was done at our center in which we have taken 15 patients which are more than 13 years of age with MD. And the inclusion criteria are patients with type 2 MD with hypertrophy of more than 10 prism diopter and FDT negative for inferior rectus, and no horizontal deviation were included. And these patients were followed up at 1 week, 4 weeks, and 12 weeks. And surgical outcome was considered successful if post-operative alignment was within 5 prism diopter of hypertrophy, and results were analyzed at 3 months. Majority of the patients they were 15 to 19 years of age, and in our study, the mean preoperative hypertrophy in our study was 28.67, and by 12 weeks post-operatively, we were able to achieve success rate in 10 patients. These are the changes in vertical deviation, preoperative and post-operatively. There was improvement in elevation deficit also. This is the table showing change in elevation deficit. There was improvement in torsion in approximately 66% of the patients. This is 9-gauge photograph of patient of left MAD with 30 prism of hypertrophy, and this is a post-operative photograph at 12 weeks. Another patient, preoperative and post-operative photographs. This is another patient with pre-op and post-operative photographs. So to the best of our knowledge, this is the first study to assess the efficacy of Nishida's procedure alone in significant cohort of MAD patients, and this procedure offered several benefits as it avoids muscle splitting or tenotomy, thus making it less invasive option with minimal or no risk of anterior segment ischemia. This is reversible procedure which improves vertical deviation and elevation deficiency significantly in patients of MAD. In our series, we have seen that in those patients in which deviation was, hypertrophy was less than 30 prism diopter, this procedure was found to be successful. And in those patients, if the deviation was more than 30 prism diopters, this procedure was not found to be successful, and we have to reverse the procedure and do the NEPS procedure in those cases. Thank you.
Thank you, Dr. Subhash. We'll discuss it at the end. Now, I request Dr. Pramod Pandeyji to give his talk. His topic is DVD with sensory exotropia, novel approach of management. DVD with sensory exotropia.
Thank you, Professor Shukla. DVDs, as we know, are again a very interesting and challenging situations. We have known them for about 125 years, and a lot of controversy are still there. Quite often, they have fellow travelers. They could be seen under all kinds of circumstances. So they congeal things, and they make management and diagnosis quite difficult at times. So what is DVD? Is a primitive reflex gone, or it means that once we were monoocular lateral-eyed animals, they had 2 eyes, crossed chiasma, and they were seeing both ways. So these were the primitive reflexes. Once we got into frontal-eyed binocular single vision, we lost these reflexes. So whenever there is loss of binocularity, primarily, then we end up with DVD, we end up with primary inferior oblique or superior oblique overactions, and smooth pursuit asymmetry and LN. So these are the things which are part of the baggage. Whenever there is loss of binocularity, we can end up in these things in different combinations. Now, there are many theories for DVD, but I think most appropriate is what is known as dorsal light reflex, that the insects and fish, the eye which is with brighter light stimulus tends to be hypotropic, intorted, and exotropic, and the eye with dimmer light stimulus tends to be hypertropic, extorted, and exotropic. So this is like a balance mechanism with the two vestibules and the eyes. So idea is to swim properly, otherwise animal is going to be swept away and eaten up by some predator. Now, DVD and ocular tilt reaction, if you see they share something, this DVD is like inverse ocular tilt reaction. DVD is driven by imbalance of visual inputs from the two eyes. That means this is a sensory, if there is less stimulus, this is going to determine the motility. Whereas OTR is driven by imbalance of the otolithic inputs from the two ears. So in OTR, you can see we have a conjugate torsion, whereas in DVD, we have the eye which is going up, that extorts and abducts. That is the DSD component with the DVD. Now, sensory deviations are, they can occur at any age, from young age till older, age group, children and adults, and account for about 25% of cases of exotropia. So they are not very insignificant group. They are quite important, and even after, once you have a cataract in one eye, they can have sensory deviation, and when you take out the cataract, things tend to get better. So both, it could be either acquired or congenital, may improve if vision improves, and DVD, primary oblique overaction, may be markers of breakdown of binocular single vision, because in these cases, binocularity is usually bad because the vision is very poor. And DVD in these cases could be about in 15% of cases you could encounter DVD. Now, DVD, as we said, it's a surgical challenge. Many issues are there. Associated horizontal deviations, you could also have a deviation and also a DHD. Imprecise measurements, variability in presentation, variable dose-response relationship, could be unilateral, which can again be a problem, because then doing surgery on cyclovertical muscles in one eye can create issues for both the eyes. It is bilateral, asymmetrical, or if it is incomitant, all those issues are going to be relevant. DVD which are larger can again be more difficult, and if there is associated abnormal torsion or pattern strabismus, like you see with superior oblique overaction in these cases, or with primary inferior oblique overaction. Now, unitary DVD with sensory exotropia, surgical challenges, correcting horizontal deviation may not help DVD because there is no binocularity. Some DVD may get better if you correct the horizontal deviation, but here the possibility is not there because the poor binocularity. Switching fixation not possible, poor binocularity and motor fusion. Surgery on more than two recti not advisable because of risk of ASI. There are multiple procedures may be required. Unitary surgery on cyclovertical muscles may produce TP hypertropia, induced torsion or pattern strabismus, and there could also be upper lid retraction if you are doing large recessions on the superior rectus. Now, rectus muscle vertical offsets have been used in a lot of situations. They don't induce any torsion. Pattern strabismus can be done simultaneously with recessions and resections, may augment motility in the direction of transposition and affect TP alignment, may be done for IXT with up to 10 PD of coexisting hypertropia also. If there is a vertical with intermittent exotropia, you can also do this. So sensory exotropia with DVD may fit the bill quite well in this situation. I'll just talk of one child. We had the 16-year-old child who had poor vision and outward deviation of the left eye, and no treatment was taken. He had anisometropic amblyopia in this eye, was myopia in both the eyes with anisometropia and astigmatism. So this eye was exo and hyper. So he also had about 40 PD of exotropia at distance and about 12 PD of DVD by the UCT. There was mild bilateral inferior oblique overaction. There was no SPA or LN. This is showing the motility, not much of inferior oblique overaction, but the eye was in exo and tropic DVD. This is showing torsion. You can see the left eye is having extorsion, though there is not much of inferior oblique overaction. So there could be a mismatch between inferior oblique overaction and torsion also. If it were due to superior rectus contracture, there should have been intorsion. So that shows that this is not due to superior rectus contracture as well. We just transpose the lateral rectus about 3/4 muscle down in both medial rectus resection and lateral rectus recession in the left eye. And you can see that the vertical and the horizontal component has been taken care of. You can see the 9-gauge position here. So things are looking quite good. Torsion has not been affected because we have transposed both the muscles, so it has not affected torsion in any way. So advantages of ITHR: simple to perform, avoids multiple procedures, less surgical time, no pattern strabismus from large recessions, no fixation duress in the fellow eye, no induction of abnormal torsion, no PP hypotropia or limitation of elevation, no upper lid retraction, can be done for both sensory ET and exotropia. Literature, there is very limited literature on this. Somehow it has been done on asymmetrical unilateral DVD, but in sensory deviation there is not much of literature, and they have done half muscle transposition, whatever little is there, and they have not studied torsion and pattern strabismus following this. So to conclude, ITHR may treat unilateral DVD up to 15 PD, may not be suitable for incompetent DVD, simple, avoids multiple procedures, and anti-segment ischemia. Sensory deviations with competent small moderate DVD may be best served. Larger series with long follow-up are required. Thank you.
Thank you very much, Pandit. And now I request Dr. Pradeep Sharma ji. He also requires no introduction. At least all of us know him very well. So he would be speaking on reinforced plications.
Thank you, Professor Yogesh. I think we are having these plications, revisiting ourselves because of some changes which have happened, and that is how we are going to talk about the newer applications of that. So as you know, for strengthening procedures, generally we have had resection, but now we are more and more shifting towards plication. I have no financial interest in promoting plications. It has been that for since I think 5 or 6 years that we have been trying to find more interest in plications, and why, I will tell you what's the reason. So you'll see here that resection is the conventional strengthening procedure, but the disadvantage, as you would know, is that it's not easily reversible, that compromises the blood supply, and also there is a risk of losing the muscle or slipping at least. Plication has that advantage that it strengthens, it's vessel sparing, shorter operating time, causes less surgical trauma, inflammation and hemorrhage, and also it's reversible in the early post-op period, and of course there is no risk of losing the muscle. Let's have a small video of this reinforced plication as I do. And in this, what we do here is that medial rectus has been hooked from the fornix approach, and on either side the intermuscular septum are incised up to 8 to 10 mm, and the check ligaments are separated. And just like what you do for resection here, we are marking the same nomograms I am using for resection as we were doing earlier. And the 6-0 vicryl sutures are being used here. And so first is you imbricate the muscle. Then next step is to imbricate the sclera. So from muscle, the sclera, and then back to the muscle is what we call the reinforced plication. So this is one bite in the sclera and then back into the muscle. This is a figure of 8. Now this helps us in folding the muscle very easily. So once you have done that and you place an iris depositor in between and you just tighten the sutures, the muscle neatly folds, and this is what we want, that the fold is buried underneath and the sutures can be tightened. At this stage you do an FDT to see if that you have not over tightened the globe, and if it is to your satisfaction you can close the conjunctiva. So this is as simple as it could be, and the steps, as you may have seen, are these that we have to talk about. So if we had done a study to compare the effects of resection versus plication, and we see that similar cases if we have, there will be redness of course in the first week period. The lump is more in the plication in the first week, but after a month the lump disappears almost. In few cases it may be there for about 6 weeks or 2 months, but usually it will disappear. And I sometimes find that the plication eye is much cleaner than what we will have post resection. The main advantage one is that it's early reversibility is possible. In resection you would have to totally undo it. Even if you went wrong, let's say you will have to do a recession of a resected muscle, you have to pass sutures and all. But in intermittent divergent squint, sometimes we come across cases when we have overdone. And in that case, you can easily reverse the sutures in the first 2 or 3 days, and you will be able to undo the overcorrection that you have done. This we have done at least in 2 or 3 cases earlier when we had a case of overcorrection of an IDS. But now we have another thing which has come over to my mind, and that is 1.5 surgery. So now what I call 1.5 surgery is in exotropias of about 35 prism diopters. So this is an in-between situation. If you remember, there was an ad sometime back of Amul chocolates that I am too old for this and too young for this, but you are just right for Amul chocolates. So that is what I say, that 30 prism, up to 30, 25, 30 prisms, 1 muscle is sufficient. 40 prisms, 2 muscle, no doubt. But what happens if you are 35 prisms? You are in doubt. And that's where I was doing this, sometimes undoing the plication halfway. So now I have started doing for this 35 prism diopter bracket, LR recession, same amount, 7 mm, but the MR is a central mini plication. It's a half the effect, and that is 4.5 millimeter bite. So this is what you'll see here. Sorry. So it's similar. What you'll see here is in this, this is a fornix incision again, the medial rectus hooked, and neatly you get the intermuscular septum on either side, check ligament separated. And now here there's just one single bite you take, sparing the vessels, of course. In both these the procedures, we try to see that the vessels are spared, and then we are taking this muscle, sclera, and then muscle bite, and then you pass the iris repositor and fold the muscle. So there is a single suture. Even to undo it's much easier now, but mostly you don't have to undo if it is a 35 prism diopters, and this is where I have started doing this more and more, 1.5 procedure. Yeah. Yeah. So this is the greens hook, and then the small hook passed, and check ligaments are separated. So this central bite is taken. Now this iris repositor is placed in between, and you tighten this suture. Both these ends are pulled, then the muscle folds on itself, and you can then close this suture. And once you have ensured that it is the right tightening, you will switch that. If you have to do a vertical shifting, will it be a problem with plication? One would think that resection is easier to do a vertical shifting, but usually what we do is half muscle width shifting for resection, and the same can be done with plication also. And as you can see here, so basically what you will do is pass the sutures and then pass them in the sclera diagonally placed. So this is the, let's say the one end. So inferior end we have passed in the muscle, then the superior end of the insertion we have passed in the sclera, and then back into the muscle. So this is a diagonal thing which is there, and the upper muscle suture will come 5 millimeters above on the sclera and then back into the muscle. So once we are going to fold, it will cause a diagonal shift of the muscle, and that serves well for our A or V patterns. When you have DVDs, we were talking about DVDs just now, and I would say if you have a inferior oblique overaction, of course you do an IO80, but if you do not have an inferior oblique overaction, what do you do? Then in that case, earlier we were doing superior rectus recessions or with Farden. I would now suggest doing an IR plication. So this is with an inferior oblique overaction, but this is without, and here we are doing a IR plication. Surgery I may not have the time to show, 30 seconds, but it's similar what you do for the medial rectus. So mini plication, which has been talked about by Kenneth Wright, I have tried to make it like a reinforced mini plication, and it works very well, especially for these small angle deviations of 8 to 10 prisms. And sometimes you have this hypertropia or the cases of Hyman-Belchowski's phenomenon, these children who have a small angle deviation happening or small DVDs, then we can do this procedure. So to conclude, plication can be effectively used as an alternative to resection in routine horizontal rectus muscle surgery, especially the medial rectus. As a mini plication also it can be used, and it corrects small deviations. So now I've been talking about plications all over, and it's received very good reception. I would like to say that we should be switching over plication at least for the medial rectus and for the inferior rectus whenever it's required. Thank you for your patient listening.
Thank you, Professor Pradeep, for very interesting talk. I think these are interesting techniques, and we need to adopt them. I think for small angle deviations, they are really good.
Thank you very much, Dr. Pradeep. Now, I would request Dr. Shreya. Yeah, please. You'll be speaking on current trends in management of traumatic strabismus. After this, Dr. Gogate. Parikshit. Yeah. The clubbing, both, sir. Traumatic strabismus is again a very, very complicated, and again an enigmatic way of treatment of these traumas, those muscle traumas, polytraumas all together. Yes, Dr. Shreya.
I'm deeply grateful to Dr. Shukla sir, Dr. Pandey sir, Dr. Dedia sir, and Dr. Sharma sir for allowing me to speak on traumatic strabismus. And we have all our own publications of traumatic strabismus, and what can happen to trauma and strabismus can be a supranuclear structure to everywhere. So if you look at traumatic strabismus, it can be immediate and late. This is the algorithm how we'll find out which kind of trauma to muscle happened. Types of trauma which can happen to muscle can be contused, can be lacerated, can be complete laceration, can be snapped, pulled into two, can be a disinsertion, it can be a lost muscle, and we all know what happens in our blowout fracture. So I'm not going too deep into pathophysiology of blowout fracture. That can be many theories existing, but I'll directly enter into the management of traumatic strabismus. Most of the traumatic strabismus you find is incarcerated or entrapped strabismus. It can happen in type 1 fracture, type 2 enteral fracture, or type 3 enteral fracture. So we have to be worried for Y-type blowout fracture, which is the first important and immediate attention it requires. RMR also can be entrapped, which in this boy it was entrapped MR. It was entrapped superior rectus. So again, you have to get take support of all the radiological investigation and fix it immediately. The 8th thing can happen to muscle is flap tear, and 9th thing can happen to muscle is muscle can slip. So how to diagnose? We have many things to diagnose. We have to do thorough workup of a strabismus examination as we do with each kind of a strabismus, including ophthalmos, exophthalmos, pupil and everything. Could be supported by USG, CT, MRI, dynamic MRI or EMG. So dynamic MRI works very best when you're dealing with traumatic strabismus. Be aware of the contusion. When there is hematoma and contusion, you can just do medical management. Clinical diagnosis also can be done where the muscle is entrapped. Point to be noted is ocular motility, FDT and FGT. So these three things will definitely tell us where the muscle is and what we should do. This is a Q-tip FDT done in pediatric patient also, and again on operation table you can do FDT and FGT. According to FDT and FGT, we have developed our own algorithm. I'll not read a complete algorithm here. Later on I can circulate, anybody wants to take, can take. So when we enter into management, we have to look for oculocardiac reflex first, retrobulbar hemorrhage, open globe injury, CSF leak and muscle strangulation. So these are the red flags. Within 24 hours we have to intervene. So in that way, and when there is a simple contusion, till that time, if you have time, you can just manage it by medical management, prism, occlusion to avoid the diplopia. When there is muscle contusion, observe, simple anti-inflammatory, resolve with the complete restoration of movement. So medical management like steroids, antibiotic, and no nose blowing should be told to patient. Even in this patient, you can say it was acquired brows just because of trauma contusion, but then later on it resolved very well. Partial laceration, again, you can find out the muscle because half the muscle is seen in front of you. You can reattach it. And long-standing cases, sometimes you may have to reoperate the case. When there is complete laceration of muscle, don't be panic. Try to find out the muscle. Muscle usually doesn't go anywhere else other than its sheath. So trace the intramuscular septum of both the sides and try to find out the muscle. Look for the muscle sheath, and definitely if you are not panic, and at the same time you are not supposed to pull the globe away from the action. So otherwise it will push the muscle more and more into orbit. So that thing has to be taken care while doing this. This patient had complete disinsertion, and post-op immediately he regained the vision. Muscle can be snapped, pulled into two. So this way inferior rectus was definitely pulled, and as I said, trace the intramuscular septum, go to the muscle sheet, and definitely you can find out the sheet. So it's very easy to find out when there is muscle pulled into two. Snapped muscle is very easy to find out. You can hold with non-traumatic forceps and you can just suture it. So this person was 30-year person, and it was published. So when you are getting old injuries, there can be scar tissue, abdity, severely positive dynamic MRI works very well. Sometimes you may have to take the support of EMG. Lost muscle is really difficult to find out, and sometimes it's very old injury. Even if you find out, you don't get the gratifying result. So then the vertical rectus transposition works very well, and you can just do that transposition. Seventh thing can happen is incarceration. Again, as I said, timing of surgery and aim of surgery is to release the muscle properly. There can be too many ways to do, and too many implants are available in the market, but you should take care of the implant. But the thing is, you have to take out all the tissues from the maxillary sinus and take enough time to take out everything, and then appropriately put your implant to take care of this. So this is again a superior rectus entrapment, this is medial rectus entrapment, and this is lateral rectus entrapment, treated very well. Sometimes we may have to go to orthopedic surgeon and treat while they are doing their own surgery. So he fixated all the fractures, and then we took care of muscle injury. But their abdity is at most important when you are taking care of muscle injury. This is post-op. He gained that can be endonasal route also. So again, so many complications can happen when you're doing orbital surgery. You have to take care of that. I'll not go into detail of each and everywhere here. The most important part over here is flap tear. So that you have to be aware, because all the muscle injury, it's front of you, but flap tear is usually is not in front of you. And more movement, the flap goes back and back and back, and then again you get the limitation of that action. So this flap tear again can be a longitudinal flap tear, that can be beveled flap tear or lamellar flap tear. You can just do dynamic MRI. All the time you will not be able to get the result with dynamic MRI. Clinical judgment. This girl had injury, and you can see the muscle, you can see very good movement, so you never expect any injury. But on table, when we took the patient, you can see medial rectus was, the anterior part of medial rectus was slide back, and then we reattached. Here you have, when you are just tying the suture, you have to push the globe towards the action. Otherwise, again and again it tears. So that is the most important part we have to take. This time when we are tying this, we have to push the globe. Tell your assistant to push the globe. So this is the way we completely suture, and this is post-operatively. So again, another flap tear was happened, that was oblique flap tear, and this is post-op. Entrap muscle, I've already told so many things. When there is tight muscle, again, you can just take care while just dealing with. When you open, and you can see, even my speculum is not going. I'll take only 1 second, so it's last slide. So management of flap tear is at most important. Sleep muscle you can find in its sheet only. So just try to find out its sheet. This is post-sinus surgery. So sometimes you can get the iatrogenic traumatic strabismus, which also you can take. So again, then later on you have to take some of the things like this vascular cause. You have to observe patient. Just simple observation can tell you so many things, like CCF. the globe is pulsating globe. So there you should have judgment of treating the patient while ligating first and then do the things. I'll not go into paralytic strabismus because it's same as traumatic strabismus and the treatment remains same. So I'll just end my talk here. Paralytic strabismus is the same and I'll not go. So just traumatic strabismus we can take care here. Thank you so much.
Thank you,
I'll
Dr.
end my
Shreya,
talk here.
for covering a very important subject. Now we move on to the last speaker, Dr. Parikshit Gogate. So after that, we will have a discussion. So hold on to your questions and comments. And so Parikshit. So you have two talks. I think you'll merge it into one so that we have time for discussion. Huh?
Yes, sir. I'll try to do it as fast as possible. I would like, Professor Pradeep Sharma, sir, a great guru of strabismus, Professor Shukla, Professor P.K. Pandey, sir, Professor Dadia, thank you, and Dr. Shreya, and all the strabismologists in this hall. So what I'm speaking is something that all of us do, doing resurgery. So one of the things that we started having resurgery is we plan to do now a two-step procedure if there was a large strabismus, rather than doing all three muscles in one go and then perhaps doing something later. So it's best to do two at a time. I mean, all of us are not as great surgeons as people over here. There can also be a slipped or a lost muscle, the MR being the most common one, if there is an abandoned surgery after trauma surgeries where we have to do. Or rarely it can happen, there is a wrong diagnosis. I have had a patient operated in a very, very famous institute where an accommodative esotropia was missed and the patient was operated and landed up with a exotropia. A wrong operating technique, which is very rare now, but it's still possible. An intermittent exotropia, if that is operated early in life, it can become esotropia later or sensory strabismus. In all of them, a resurgery is needed. Again, in restrictive strabismus, the dose-response relationship is not very accurate and something may have to be done later. And all the wonderful videos that Dr. Shreya showed, secondary to trauma, secondary to paralytic strabismus, we may need to do something later again. Also, this is from JPOS. This is the American Academy of Pediatric Ophthalmology's clinical audit. This almost 60% of strabismus surgeries in the US have a post-op deviation of more than 10 prism diopters a decade after surgery. So even in the best of places, with a long-term follow-up, the alignment does change. So a need for a repeat surgery is not very uncommon. Generally, if it is less than 10 prism diopters, we would not think of it. Even in younger children, less than 4 years, we would not think of a repeat surgery. And overcorrections up to about 8 prism diopters may be accepted. And nowadays, there are Fresnel and stick-on prisms which can take care of that. So what to do? One is, of course, to do a very thorough preoperative checkup, to do a force duction test, a complete orthoptic evaluation. And we draw a surgical plan and we counsel the patient because it's a resurgery. So we need to spend more chair time with the patient, telling the patient what it is that we plan to do and what it is that the patient can realistically expect. So in esotropia surgery, a recess resect surgery has lesser chances of undercorrection than bilateral medial rectus recess surgeries. This is our data. And if initially bilateral MR recess was done, we could do an MR marginal myotomy with LR resection or bilateral LR resection. As I've grown older and we see more and more of our patients who were operated 10 years, 15 years, 18 years ago, I have started doing more of bilateral recessions than doing a recess resect, because with a recession, it is more easier to do. Or as Professor Sharma was saying, instead of doing a resection, perhaps we should think of moving on to plications because something later may need to be changed. Again, we do surgery for undercorrection of esotropia or for overcorrection. I'll just run through this. So generally, when to reoperate? Well, definitely after about 8 weeks, ideally after 3 months or so. But if there is a lost or a slipped muscle is suspected, when there is a sudden, large, often consecutive strabismus, only then is early intervention beneficial. Again, in a resurgery, the dose-response relationship is difficult to predict. So if we are doing adjustable sutures, this is a great place to do it. They need skill and patience on part of the surgeon, but also they need faith and cooperation on part of the patient. So they can be done only in a subset of patients. They can't be done in all patients, especially for very young patients. They may need a general anesthesia again, which is difficult in many private practices and many institutes. So if there are adjustable sutures, definitely the outcome is much, much better, much, much more predictable. And we can have a short GA for children and uncooperative adults. An adjustment is done on the second post-op day. So again, there are two randomized control trials from GNAC Delhi and KGMC Lucknow, and both of them found, one of them found that adjustable sutures were very good, and the other from GNAC is saying that perhaps it's not that great and we can just go on with our routine dose-response relationship. Again, consecutive exotropia is seen, and consecutive exotropia can be checked. This is a study, a Polish study published in a German journal in which they have had 21 patients, of which 19 patients of consecutive XT, so ET operated and then XT. There, at least one previously operated extraocular muscle, and the surgery is done after a few years, and they have found that the results are much, much better. In thyroid-related strabismus, again, if a resurgery is planned, again, weak magnetic implants, scleral implants can be thought of. Horizontal rectus muscle transplantation may be needed for long-term follow-up. And another, which what our seniors always tell us, is when we do an evaluation, we should also evaluate always the obliques and the overaction and the underaction of the obliques. And if needed, tackle the obliques there and then, because if they are not tackled at that point of time, they can also lead to an unforeseen consequence, and later we may need to do a resurgery, which is what the Gobbins method is. So finally, the pitfalls in resurgery, one, like in trauma, normal anatomy is disturbed, and identifying the muscle needs experience, skill, and patience. We have to be prepared for surprises. The results may not be always as good as when we are doing a primary surgery. And if in doubt, it is better to grade the surgery to tackle one or two muscles at a time rather than attempting multiple muscle resurgery, because we do not know how the resurgery will go. So I will just go on to the second one, which is just 6 slides. That's a talk that is very close to my heart. That is on training and training of strabismus. So one is, what can we do for training the wet lab for our residents? The reason is, this is the READ study which we had done about 10 years ago, in which we had compared the 20th century trained ophthalmologist with the 21st century trained ophthalmologist. This was done when Dr. Partha was the chair ARC, and now as a president, he wants to do it again, because in 10 years, the AIOS, all the SPOCI, all the societies have done so much to make training better, but we do not know what difference we have made in the ground. In almost all subspecialties, the training in the 21st century was better for glaucoma, for retina, and for cornea, because there is so much of technology, so much of gadgetry. Only in one subspecialty, that's ours, sadly. Orthoptic evaluation, in fact, the 20th century trained were better. Pediatric visual acuity testing, hospitals buy OCTs worth, say, I don't know, lakhs of rupees by corneal topographers, but they don't have vision acuity charts to measure vision of toddlers. They do not have stereopsis chart to look at simple stereopsis of people who come to us. Synaptophore testing is an art that is unfortunately, I think, endangered. I will not say extinct. Even Hess diplopia charting is not there. And one major thing was, in the 20th century trained, they were doing about 13 strabismus surgery. The median was 0. So even in the last century, half the residents had not done any strabismus surgery. In this century also, the median is 0. Half of them have not done any strabismus surgery. But even the mean is just 1. So I was lucky to be in a residency where we had Dr. Milind Keledar, Professor N. Kulkarni, who taught us strabismus surgery. But then in today's residency, hardly anybody, because everybody is so focused on learning cataracts, they barely get to learn phaco. They are just at SICS. That strabismus is something that is way off the radar. So what can be done? Because the surgeries performed independently during residency for most subspecialties are zero. They are zero. If residents get cataracts, they are happy, and perhaps some chalazions and trauma and pterygium. That's all that it goes to. So we need wet lab training. There is a huge amount of energy, money expended to teaching SICS, teaching phacos. We have simulators, we have this. But there is not that much for any strabismus surgery. So one is, this is a study from North Carolina and Seattle, Washington in 2 centers. They also said it is very difficult to get cadaveric extraocular muscles. The DCR chaps do try on the cadavers. So here they use strips of bacon, which is very easily available, or strips of pork as an extraocular muscle substitute, and used cadaveric pig's eyes so as to do teaching of at least the basic muscle surgery. Then there have been simulators that have been used. They are simple simulators, and they found that the simulators were portable, inexpensive, and I think we will need this in our country, and premier institutes should start having them. And when the residents were taught on simulators, it was almost as good as teaching in a biologic wet lab. So again, there is a structured structural simulation curriculum for strabismus in the University of Iowa, where they are using to see how a resident's comfort level improves in identifying a muscle, cutting a muscle, and resuturing a muscle. And they found that it is very useful. And finally, they have also used cyanoacrylate glue, because in very high myopic individuals, or where the surgery can be risky, so instead of taking sutures, you use cyanoacrylate glues. But again, they have used frozen bank rabbit heads. Now, getting a frozen rabbit head is difficult. In the US, yes, they could do it. But that is another way that they have tried. And this is a strabismus model that is there, which I think we can easily have, and that we can learn to isolate muscles, create adjustable sutures, and secure permanent knots. All this is important because it is unlikely that residents will actually get to learn a lot of surgery of strabismus, because strabismus surgery is a reducing art. In the United Kingdom, as the amblyopia program started, the number of strabismus surgeries that the NHS has been doing has fallen steadily from 1980 to 2020. And as the amblyopia therapy gets better, strabismus in children is going to get less and less common. So the need for strabismologists in the NHS is less. So this trend will happen here also as the birth rate reduces. So we cannot teach our residents on patients. We will have to learn to train them on wet labs and simulation. Thank you.
Thank you, Dr. Dr. Gote. Now, the house is open for any queries and questions from the speakers.
Yes, Dr. Leela. Mike. Maybe as panelists, you can come on the first row also. So if there are any questions, Sucheta also. आप भी आगे बैठ जाओ.
During our last midterm SPOSI conference, we had a wet lab where we utilized, it was very tough to have the wet lab for, not like Alcon, we have the wet lab for cataract surgery, it's easy. But Goat's Eye, we managed to have a wet lab with the feel of the actual muscle, with and the scleral bites and everything. I think Dr. Pandey has seen that, no? We had a wet lab on fresh Goat's Eye. It's not useful if it is not used within half a day, because the chamber collapses and then you don't get the bite. And it was very difficult for us to make the wet lab on Goat's Eye, but it was useful, not the models. With the model, the scleral feel and the it's of no use actually, not like getting used to a phaco machine, because you need the actual bites on the sclera. So it is little difficult, but we had it during the midterm conference. We could make it.
So I think maybe Sposi, whenever next time they can have that as a requisite thing.
Yes.
Yes.
The wet labs for the.
And what we use in our institute, Dr. Parikshit, it's once we purchase, it's being a Orbis center, it's mandatory to use wet lab. So what we do, we just purchase simulator, but then every time we cannot purchase the dye. So we just redo with the clay, and then our residents and all fellows are working on that. That also is a cost effective and works very well.
So,
once
I would like to ask Pradeep sir. Sir, do you give your residents, because you have been training people in AIMS for generation, one step at a time in your paid surgeries? Will that work better?
So when we were in AIMS, of course, the residents had a good chance of doing surgery because the volume was good enough. So all the residents would have done by the time they passed out at least 10 strabismus surgeries. So that would be there. So, but that is of course not possible in many of the private centers. Now, for example, now I am in private practice. So that's why I have tried to say no to fellows, because I cannot give them to operate. That's what the mandate is not allowing me to that. So we just have observership. But yeah, if there are models which can be used, then
What about
probably
giving
that
it
can
in our private patients one step at a time, like
yeah.
hooking?
So one step at a time we can, but that is not enough. I mean,
But that
we do
is-
give
yeah.
maybe suturing, conjunctiva or something that will be there. So that's sure. It's
But that is
possible.
of no use, you know.
But
you
that will
just-
be. But no, I would say more important in strabismus is understanding,
Yeah.
planning.
Concepts.
So I say that generally it's the recipe I have been saying is OCIP: observation, confirmation, inference, planning, and execution. So execution is just one step. The 4 steps are more important, which have to be done. And if the people in the observation can do, and I'm happy, most of them, one of them, Manisha is here, I think she can also tell. So that helps. Even in 3 months, you can imbibe the way how you have to examine a child, how to make your diagnosis, how to infer which muscle to do. So I think doing a surgery in strabismus is not as difficult as to find out what to do, which muscle to do. So that is the important part. So that way I think it's there.
Dr. Pradeep, I want to ask you a question. You said that your placations which you have been doing is more for medial rectus and inferior rectus, not on lateral rectus. Have you ever tried on lateral?
So, no, we have done on lateral rectus, and lateral rectus there is a good study by David Hunter, and he has shown that on the lateral rectus there is chances of undercorrection coming up later on. But more than that, the reason I have been restricting myself from rather than doing lateral rectus is the exposure part. It's more on this
Yes,
side.
that is
Secondly, LRs are always requiring more surgery. It's 1.5 times more surgery you'll do for any muscle. Medial rectus, if you do 6 maximum, lateral rectus is 8 or 9.
That's what I was,
That becomes too much lumpish. So that's the reason I have avoided. But yes, I have done in some cases on lateral rectus also. It works, provided you have
do a
that
small.
lump
When,
allowed.
yeah, you have,
It
when
will
you
take a month's time to
But if you
disappear.
have a small, sir,
And sir, how much?
About Parikshit, I wanted to say.
Sir, how much
squint-
maximum you
Squint
can?
incidence and prevalence, I think with us it is increasing because we have more and more myopia and more premature children which are surviving. So the strabismus actually is not going down with us. More and more exos, particularly now, I think. When we were younger, we saw more ESO. Now ESOs are less and more exos we are getting because of probably
And
myopia.
sir, how much?
To ask you about the placation. If you see on the second or third day it is overaction, do you correct it on second, third day? Because most of the time the overcorrection becomes normal.
Normal.
Undercorrection remains always undercorrected, but overcorrection becomes.
So you have to see how much. So what you need to do is measure it. If it is up to 8 prisms, probably you can let it go in intermittent exotropias. But there also you'll have to manage, counsel it properly because they will be disturbed by the diplopia. Most of these are having binocular vision, and we want them to have their binocular vision maintained and better. So up to 8 prisms, okay, you can give time. But if it is 10 or more, you have to intervene and reduce it. You don't want to keep it like that.
Sir,
So up to 8 prisms, if that diplopia is bothering them, we give short-term prisms.
And
Yeah.
When
sir,
the plication
said-
follow period is less. No, we don't have a long-term follow-up as of now, maybe after
No,
another
no, no.
10
We
years.
have had now 5 or 6 years.
That's still not very long.
So that is pretty good for anything that.
And sir, I have
Actually, I
question.
would like to know, sir, you said after 2 days you could undo it.
Yes.
But sometimes you ask the patient to come after 1 week and then I've had trouble undoing it.
Correct. So after till 1 week we
lication.
have undone in one case that came later. So after 1 week also you could do, but you have to do little more manipulation then, because then you have to ensure that the globe is pulled out, because there have been adhesions already. Adhesions start forming after 7 hours. So after that you will find that more and more you delay, the more adhesions become stronger, and that's one of the reasons why 60 Vicryl will work in spite. Many people had a feeling that what will happen after that, but by 1 month it's very well healed. So that concern was there in some people. You're not making the muscle raw. Will it attach? It does attach very well, as good as any other.
And sir, how much
Reversibility is
maximum
within
in?
1 week.
I'm sorry.
Reversibility is within 1 week, you have to decide.
But
So within 1 week you can decide the reverse.
when you are doing the dressing the next day, I think after 24 hours is enough to find out whether it has been. So that time only you can do it if you find a gross, if there is any gross.
Correct.
And
So that is there. So reversibility is there, but yeah, you definitely want that your primary thing is more corrected properly. And here I would like to say that in squint it's very important that we are not interested in half the surgery. Now in cataracts you don't do a little bit cataract left and you are happy, no? So how can you be happy that I have reduced squint and I am happy? No. You have to ensure that entirely the squint is corrected in what you want it to be. You have to, as I have been trying to stress again and again, our goal is not strabismus surgery, it is restoration of stereopsis.
Binocularity, yeah.
And I don't know how many of you use stereo testing as a routine.
yes.
In all your cases,
Everybody.
pre-op and post-op,
Yes.
yes,
Yes,
you
sir.
need to do a
Yes.
stereo testing. That is our goal. You have to, and that will also give them confidence. Parents will come to know, sometimes they are asking, what are you doing? Red and green color testing when they see a TNO. They know this is not color testing, this is for stereo testing. And when I show them that you put up yourself, then they feel, oh, that's the different world. A 3D world you have to restore.
And sir, I have question.
But some people like to do surgery on in exotropias. They will operate one eye and then they say whatever is left we will do later. I think that's not the right approach.
So
to
you
do.
have to, or you have to do with
go for
counseling. You have to
whole
ensure them. If it's a, let's say 90 prisms and you are doing only one eye, you are telling them beforehand that look, I may not achieve more than 60 and maybe the 25, 30 which is left, I would do again. So you need to take them into confidence. It's very important because strabismus people are not having that much of awareness.
Sir,
Yeah,
how
but
much
in any case,
maximum
no, you
we
in
can
any-
do for AV pattern? You said plication. So how much maximum you can
Shifting.
do? Shift. How
Shifting
much?
for, even for resection, what we have seen is half muscle
Half
width
of
is
the
what we were doing. More
Not
than
the
half
full.
muscle width, it becomes actually a vertical transposition.
Yeah, that's why.
So
I'm-
up to half muscle width, you can easily do with plication.
okay.
Also there are about 10 diopters there.
saying that squint में surgery से ज़्यादा it is more of an understanding.
Planning.
And also in your diagram you showed about the RF ruler and synaptophore. So I think synaptophore से you can understand better. Means,
It takes more
what is-
time.
What is meant by separation?
Takes more
You
time.
can show it to the parents also. When
No, but
Nana is
Dr.
open,
Abha, nowadays with
Yeah, I know
the
that.
binocular glasses, no?
Glass, yes.
With when you show the stereo testing, that itself will show how much is there.
But
Bagolini's. So you need to do tests which are more physiologically appropriate. And
Take a-
synoptophore is good. I'm not saying that. But the role of synoptophore is not required
Now.
in all cases. For residency training, yes, they should be well versed in that too. But I would say that it's not the real thing that we are forcing on them.
देखिए आजकल जो वेक्टोग्राफ्स आ गए हैं ना, you have those, you know,
And now
glasses.
with these oculus, you have again a possibility of doing away without the stereo. The binox is giving the treatment again using the red and green glasses, again not requiring synoptophore. You can do suppression, anti-suppression.
आप जो वेक्टोग्राफ पे करोगे ना,
Exercises.
आप पेरेंट्स को भी सुनिए आप पेरेंट्स को भी बैठा के दिखा सकते हो कि देखिए ये बाइनोकुलरिटी है.
But
So,
yeah,
polarized-
synoptophore we are not denying, but it's not mandatory. I would not say that everybody may be or should be having.
When surgery was not good in past, then orthoptics
Yes.
and synoptophore were very important, I
yes.
think, very vital. Now with better surgery, I think things have changed a bit. Now we are more surgical.
So how do you exactly revise your plications?
Please.
I mean, you cut the scleral bite and then make it a mini plication type, or how do you revise? If you have to decrease the effect of your resection or plication.
So in plication, if you have to do, if it's a central mini plication, just one suture you trim, and in the initial part, if you ask the person to rotate, it will, the muscle will slip behind. In 2-3 days time, it does. If you may have to use a forceps to ensure that the globe moves, if it is tight. If it is both the ends have been taken, like it was a full plication, then you will decide whether to snip only one of the sutures or both. So that can be done.
So then,
depending on how much overcorrection you've got.
Now, if you snip one, it may create incompetence also.
Little
maybe.
bit is there, but it doesn't really, in binocular cases, they will usually fuse. So we haven't had any problem with the one slippage, suture cutting.
and so how do you ensure that it is that it's a vessel sparing surgery? Do you spare the vessels while taking the bites?
So as far as possible, you should spare the vessels all which are visible to you. So that should be done. That is what we want. So in central, you will have easy thing because the two vessels are running on the side. When you are taking the two bites in the medial rectus, the vessels are on the side. So you have to be careful that you separate them and you take the bites in the muscle and sparing the vessels.
So have you done a resurgery on these plicated muscles ever? And how does the muscle look like?
So the interesting thing is that we haven't done resurgeries on plication, but in AIMS, Dr. Amar Pujari, he's fond of doing AIOS2025. So he did AIOS2025 on some of these cases which we had operated on plication, and he has seen that after about a month or so, the muscle gets like morphed. There is a morphing of these muscle fibers, and then after a month or two, they become inseparable.
So they will be shortened. The muscle will be shortened.
The muscle gets shortened, of course, and these will get almost absorbed.
And Dr. Parija.
Logical studies on the experimental
May or may
studies.
not, but
Maybe
AIOS2025 works shows that yes, that is resolved.
Animal
Can I
models
ask
probably
you
will be better
something like
option.
we see large XTs after operating for congenital ETs, and when we go and do resurgeries, we see the muscle is in the exact position where we have kept and not much of refractive error. How do you explain it? Like what could be the reason for that?
Say again, what you?
I've done, suppose I've done a surgery, bilateral MR recession for about 60 prisms. I've done a 6 mm recession, and the child comes after maybe 5 or 6 years with a large XT. And I've done resurgeries, and I've seen that wherever I've kept the muscle, it's there only.
It's there means it was not found
No,
to be
no,
recessed.
nothing, no.
No.
No, I have.
Find them recessed, yeah.
And it is recessed.
Actually,
I mean, it is recessed at 6 mm.
Actually, some of these could
and
also
the child
be,
was ortho.
some of these could also be infantile deviations which have a component of DHD. So if you have not taken that into account with passage of time, DHD takes over and they go into an XO. That is another possibility.
I have the records.
What is
like
the question? The question is how do you explain the
how do you explain
conjunctive
this
exo
large
happening?
XT?
Happening.
Happening.
So the reason for that, one is simple, that you have not corrected well. You
But
may
it was
not,
ortho.
No, ortho was there.
Post-op.
Refractive accommodative esotropia may have been surgically operated. That is one common thing. It can happen with us also. Why? Because when we have given glasses, the child may not be wearing it all the time. And when you are measuring, the accommodation may not have relaxed fully.
I meant without refractive errors. We do proper refraction for all of them. We have the records of all of them. But I have never been able to
If you
explain
are doing
it.
large
Some
recessions,
cases will happen.
if you are
It's
doing
not so
large
common.
recessions by say about 8 millimeters, you were doing earlier, there was a window when you were doing 8 millimeters recessions on the MR. Then this is happening. I've seen some cases where they go for XO in later part. What she's saying.
My explanation for this question is that
It is a known. It is a known. It is a known.
my explanation is that most of these children with esotropias, they may not have fusion. So there is no fusion, and in long term, there is, because of absence of fusion, the eye diverges. Divergence is the
Correct. I think that's a very important thing. That
Sometimes,
also
you
comes
know.
to this fact that why we have what we mentioned 60% cases where 40% are resurgeries. The reason is this, that you have not achieved binocular vision restoration. You have not operated in time. If you operate in time, infantile esotropes, we are getting binocular vision nowadays. Many of them are getting stereopsis.
Or more
So it is not that
syndrome,
infantile, no, they are having stereopsis. we have got so if you're operating within 1 year, 7-8 months, that some of the cases which we operated, they are having stereopsis and they are very happy. So, and they remain good. Stereopsis is the lock which keeps the
Eyes together.
eyes locked into each other.
It is important to know that these are infantile, these are not infantile. I think that is important thing.
No, accommodative. Even Panditji, even in infantile esotropias, you have to rule out the accommodative this thing.
That of course.
That is when because in children they don't do refraction properly.
One more thing I would say is that for a conjunctival closure, I usually use fibrin glue. If I use fibrin glue and we do the mini plication, it will be very difficult to revert the mini plication. Do you think so?
So I don't use
With the
fibrin glue, fortunately.
I use glue.
I
only.
always use suture.
I
ma'am.
use suture.
I use
Yeah.
glue and
More
it's very comfortable
It
for
is
the
very
patient.
economical.
Very
Yeah.
comfortable for the
remove the
patient.
fibrin glue also,
And
ऐसी कोई बात
For
नहीं
each
है.
So I
patient
think
we
there
cannot
are
use
people who
fibrin
use fibrin
glue.
glue. Do you use Manjula? No. So I think we have been using suture, but yeah, if fibrin glue you have problems, I think you. But is
But
it
for
like
mini
in first 2-3 days
plication
also you
only.
cannot separate?
Can separate, sir. Used glue before. Right now, I'm not using because I
Yeah.
feel not much of a difference, and the cost is so much
Yeah,
That's
easier on
what-
the patient.
Cost
Secondly,
and no
the
great
adhesion may
difference.
appear to the sclera, which we don't want.
Yes, that is another.
In the conjunctiva to conjunctiva apposition, I don't want adherence to the sclera
True.
in strabismus. So that's another reason I avoid doing fibrin glue.
Sir,
Yeah.
to the question she asked, I feel some of these kids have periventricular leukomalacia, which we actually don't image.
That is a separate one. Now I think because we have already crossed the
There
time.
are some changes which happen over a period of time also, what she mentioned.
You say that it is
Ma'am,
a
I
known-
think it is just
see,
that
it
as
is
a
known-
child grows older, their alignment changes.
Yeah,
Like
that
when
is-
we
yeah.
put a lens in a 2-year-old, by the time they are 10-year-old, how much ever formula, whatever we have used,
eyeball is
they
enlarged.
land up with -9, -10, and you are
See,
horrified.
whenever you operate on an infant or a small child,
Growth of the
you
eyeball
always
is
tell the patient that change is going to occur and it will need a reoperation. You must tell beforehand.
I just want to
आप
know
complain
about
का तो कुछ नहीं कर
IXT.
The chances of amblyopia are more. So even if the child remains ortho for some time,
I think
chances of amblyopia are decreased.
Exactly. So you should try to achieve that. So that will help.
yeah, we
I
will
think we have had very good, interesting
yeah.
session. Thank you all.
We'll close
Photograph of all
the
the-
we'll close the session and thank you very much for all the speakers and delegates for coming. Thank you very much.
Photo.